All right. Hello, everyone. Thank you for joining us. I'm Dr. Brandon VanderWel. This is the Eviva Weight Loss Treatment Options Seminar. And today we're going to talk about all the different options that are available to people that are struggling with their weight. And that is a lot of people. So 40% of the population of the United States, in fact. So who are we? This is our practice, Eviva. We've been leaders in bariatric surgery and innovators there for almost 20 years now. First in the Pacific Northwest to do a laparoscopic sleeve, first in the world to do an outpatient laparoscopic sleeve and an outpatient gastric bypass. Done a lot of papers. We're the first in the Pacific Northwest to do an endoscopic sleeve, the gastroplasty, the ESG. And yeah, it's been a great journey. We have a great team, two bariatric surgeons, myself and Dr. Landerholm, bariatrician, nurse practitioner. We have two dietitians and two surgery PAs. This team is great. I love working with these guys. They are they really care. They're experts in their field, and they love helping you. And that's why we come to work every day, and that's why we love the job that we have. We get together on a regular basis, discuss all the things that are going on, how we can make things better. If people are struggling, what are some different ideas of how we can help them? And it's just a great brain trust, and I love working with these people. And all of our support staff at Eviva, they're fantastic. Saw a bunch of patients today, and they were all just had great things to say about the staff that they've interacted with. So let's take a look at obesity from a 30,000 foot view. Why is it so hard to lose weight? And when you step back and take a look at it, our bodies are really not made to live in the 21st century. Your genetics don't believe that comfort and abundance is a thing that you're experiencing. It is built to survive hardship and scarcity. You think about even just 100 years ago, and that's nothing in the terms of biology. 100 years ago, your living conditions were very hard. They were small, they were not climate controlled. Your jobs, all the work that we did was a lot more intense, labor intensive. It was difficult. It was, out in the elements. It was hard. It was long. Transportation was very difficult and very uncomfortable. You couldn't go very fast. You were, still subject a lot to the elements. It took a lot more calories than it does now. Now our cars practically drive themselves. You're spending like 10 calories while you're going even long distances in some of these cases. And the food that we eat is totally different as well. The way we get our food, the way we store our food, the way that we make our food is just completely different. You just think about now, if you want to eat some pasta, you just go to grab a big box and make it. Before you'd have to like ground the flour, press the dough, cut it up. Like the process of getting food, storing food is completely different. All of these things are a setup to go in the direction of making it more difficult to manage your weight. Our bodies really don't think you're going to survive the winter, and they want to save and conserve as much energy as possible because life is hard. And we got a lot of problems in the 21st century still, but refrigerators in Costco and sedentary lives with climate controlled houses and jobs and cars that drive themselves have made it much, much more difficult to manage our weight. I break obesity into 6 things. It's the way I approach obesity. Mindset, diet, exercise, psychology, support on this hand, biology on this one. And biology is king. If your biology is struggling with obesity, it doesn't matter what you do on this hand, you are fighting this uphill battle against your body. These tools we're going to talk about, these are tools to help us with this. We all work on this stuff too. All of us have a room for improvement here. But we're going to talk about tools that really help with the biology piece to really change that uphill battle into a downhill battle. So you start working with your body as opposed to against your body. So many of you have heard and have been told that you just need to eat less and exercise more. You need to try harder. Remember the show The Biggest Loser, where they put people through that really struggle with their weight. They put them through, intense exercise and very strict diets. Gained, lost a bunch of weight on a TV show. Most of those people gain their weight back, and most of those people go on to do surgery. Done surgery on some of them. And this is the mantra that it is really only works for about 5% of people, unfortunately. So, with that being the case, what are the other tools we need to do? Because effective, like saying eat less and exercise more, is not an effective public health intervention. We need to do something else in the 21st century. Diet and exercise, like we just talked about. Sufficient weight loss is, generally not very good. On average, it's 5%. And then 5% of those people are getting, significant weight loss and are able to maintain it. But the durability is very difficult for most people that are turning into this, have experienced the weight yo-yo. You lose some weight, you gain it back, gain back more. And you just keep going on this cycle for years, decades. And it's really, really frustrating. It's really difficult because you're fighting that biology. Complications aren't not a lot of complications, just frustrating and disappointing. So let's talk about, next thing we're going to talk about is medications. So this has been a really exciting field in the last several years. I'm going to break it up into kind of traditional tablet form medications and injectable medications like the GLP-1s, like semaglutide, Ozempic, mounjaro. So the non-injectable medications, so this is like phentermine, naltrexone, Wellbutrin. There's a bunch of other things that we use for weight loss. Their weight loss is about 5 to 10% on average, which is not bad, not terrible. Durability is okay, generally as long as people, if they come off of those medications, it does get harder to maintain it because that's a tool that only works as well as long as you're taking it. You can build in some healthy routines on this hand that really sets you up for success for long term. But that biology piece, when it's taken away, the medication is taken away, it is more challenging. There can be medication side effects. That can be anything from like hypertension or tachycardia or anxiety or sleeplessness to, not feeling good, any number of things that can happen when you take some of these medications. They are mild side effects are common, but it's not like everyone's getting it or has to stop it. But we do watch it carefully. That's why these are medications that we have very close follow-up on initially, just to make sure that you're tolerating well. Weight loss is okay, like we talked about, and it's slow. It's on the slower side, which is okay. Sometimes helps it be more sustainable for some people. So let's talk about kind of the newest kid on the block, probably the most exciting thing that's happened in bariatrics in a while, and that is the GLP-1 receptor agonist drugs. So these are the injectable drugs. I'm sure your social media feeds are blowing up with this. They've been pushed hard the last couple of years. This is semaglutide, which is the generic name. Brand names are like Ozempic and Wegovy, and mounjaro is a little bit different version of this, which is GLP-1 plus GIP. These medications have shown some really exciting results. We're seeing 10, 15, sometimes close to 20% total body weight loss for some of these drugs in some of these trials now. Those are great numbers. We haven't seen those numbers from a medication, really in a long time. And even fen, which was, considerably more, we found out was much more dangerous, was getting not even quite this good of results on average. Durability, though, the results so far that the durability, after you stop the medication, is really hit or miss. These drugs are big guns. So GLP-1 is a hormone that your body naturally produces. It decreases, your central nervous system's appetite drive. It also does gut hormone changes, acting to slow down your intestinal motility and also to slow down particularly your stomach emptying. These are real tools on your biology, and those things are doing something. And when you take them away, your body is like, can actually go into withdrawal. We have protocols to wean people off of these so that they can get the most sustainable success with these drugs. These drugs also really can induce a very, very much decrease people's appetite in ways we haven't really seen since surgery. Because of that, you need to, if you're using one of these medications or thinking about doing one of these medications, you need to do this in a safe way. And by safe, I mean you need to have, a nutritional plan watching you to make sure that you're not just losing fat and muscle. When you're losing lean body mass, you're going to decrease your metabolism. It's going to actually be worse off than when you started this process. And when the medication goes away, this has been seen in the data that you gain a lot. You can gain more weight than before, and it's actually more fat than you had. And you actually have more fat on you than you had before. So doing this medication these are exciting medications. We've seen some great success with patients We have ways of, of trying to make this affordable for patients as well. They can be very expensive, but I can't stress enough that these are pretty big guns, and they need to be done with experts, and to have really good support and follow up, and the support that you need to really set yourself up for success for number one, getting the most weight loss, and number two, being able to sustain that weight loss in a real fashion long term, and that you're getting healthy weight loss. Their downsides are that their GI symptoms are common. So usually we titrate up till honestly you can't tolerate them, and that's usually there's nausea. Sometimes there's abdominal or intestinal things like diarrhea. Some people just don't feel very good on them. Some people describe it as morning sickness, and that's generally dose dependent. The doses that we are using these medications, they are natural hormone in your body, but they are at several times, not quite an order of magnitude, but like 5x times what your body usually sees. So it's a heavy gun on some of that stuff, but we're seeing some good exciting results. Downsides is that they're expensive and they can be hard to get and find. They're very popular right now, which is cool because there's a lot 140 million plus people in this country that struggle with obesity. So it's really cool that we have something that's much more approachable for patients, but it can be very expensive right now. We have ways of trying to make sure that the cost is, there's coupons. We have other ways that we work with patients to really try to be this as affordable as possible. And yeah, but they're good tools. But the weight regain is a thing when people stop them, especially if they stop them cold turkey. So we have a process to taper patients, and we watch that carefully to make sure that you are able to maintain your success as much as possible. So that's kind of our medication section right there. Now we're going to move on to the procedures, into the procedure world. The next one of that, there's my semaglutide, tirzepatide, that's mounjaro. Endoscopic sleeve gastroplasty. So this is the ESG, the endo sleeve. This is technically a non-surgical weight loss procedure, which is very exciting. There's no incisions, nothing's completely removed from your body, which is what really appeals to a lot of patients. Its recovery time is much quicker than surgery. It's done using this Apollo overstitch device. That's this. It goes on the end of an endoscope, and its suture is able to able to allow us to suture. It goes down through your mouth and into your stomach, and your stomach, which is this big bag, it takes small bites of there and then crumples it down into a small sleeve-like shape. Take full thickness bites of that stomach so that it's good, solid, durable sutures in a pattern that allows us to continually crumple down that stomach. And we're seeing some exciting results with this. We're publishing a paper right now, seeing 23% total body weight loss on average, which is very good for something that's not surgery. There's nothing else like it when it comes to something that's not surgery. We're getting better results than the lap band did. Certainly better than the intragastric balloons. We are getting better results than our GLP-1s. So yeah, this is a really cool tool. Its durability is really good because you're using permanent sutures inside of your stomach here to really crumple it down and make it much smaller. Well-placed sutures are going to stay in the stomach 90% of the time long term if you take care of that tool. Complications are very rare, which is great. It is endoscopic, so you're working inside this space, but our tools are limited, so there's less things that we can have issues with. Our complication rate is very good. It's less than 1%, it's 0.7%. And the complications that we've all had have all been very mild. Like one patient's needed to have a little, it had a cramp, had to get dilated, and a couple of blood clots that are manageable with some medication if needed at all. So these are exciting tools. These have been really cool. The downside, I'd say, is that it's self-pay right now. It's not covered by insurance, so it can be a little bit less affordable for some patients, but this is still considerably cheaper than a bathroom remodel. Limited long-term data. So we have one 3-year paper from a practice that has 3,000 patients in it that shows durable results. One 5-year paper that shows durable results. We have been doing ESGs for over 3 years with hundreds of patients, and we're seeing some good durable results as well. But it's not like we have 10 years of data like we do with the other surgeries. The recovery time is about 4 to 7 days. I usually tell people this is like having a stomach ache for about 2 to 4 days is what it's kind of like. And you just feel like, whoa, I don't feel that good. It's not, most people don't describe it as like pain, like, oh, I'm sore right here. It's like, bleh, I'm just kind of like, my stomach got tightened up because that's what happened. And then one morning you wake up and you're like, oh, yeah, I feel way better now. So that's cool. Yeah, and then we have very very clear description of what we want you to do from a portion size standpoint, from a calorie standpoint, from protein, carbs, and we build a whole nutrition plan for you after these procedures. I think the follow up on this procedure, particularly as well as the surgeries and the GLP-1s, like I said before, is very important for getting the most out of this tool to get the best success, and also to set yourself up for maintaining that success long term. So now we're going to go into actual surgery. So this is laparoscopic bariatric surgery, which is using incisions and a camera, and that we're able to see on a screen, and small instruments that are about this big. Got this guy right here. This is the stapler, where you are able to use the space inside of the abdominal cavity to then reduce the size of the stomach, which is that big bag again, from that big bag down to a small tube, and you remove the extra stomach for a laparoscopic sleeve. The way that's done is with this stapler device. You can see here, and you can see what that does is it actually clamps down on the tissue like this, and then all those little dots, all those little holes in there, they're tiny little staples, like 2 to 3 millimeters in size, makes a layer all the way around there, and then cuts in between it. So it's a very nice, a very clean, precise way to do a surgery. It's a beautiful way to do surgery, honestly. And you can see here in this picture, this is where the surgeon has the stapler, and they are they're marching up the stomach and just honestly just making it smaller, making it a sleeve shape, and then extra stomach comes out. Patients always ask, like, well, what if I need that stomach later? And I say, this surgery, as well as the endoscopic sleeve, really what we're doing is we're giving you a 21st century stomach. In the 21st century, when we have refrigerators in Costco, we don't need stomachs this big. And I firmly believe that 90% of the population could have a stomach way smaller and they would do better. That is because our stomachs are so big, they're big capacity organs, so that, think about 500 years ago, you get the gazelle. You need to eat as much of that thing as possible because you don't know how long it's going to stay. The harvest comes due. You need to eat as much of that as possible and store it. Store that food as fat because you don't know how well it's going to keep over the over the winter or over the whatever season is coming up next. Food, your body was its own refrigerator, and your stomach needed to be able to eat as much as it possibly could every time you had the option. In the 21st century, we just don't need stomachs this big. We really don't. I have big male patients even that are living their best lives with these small stomachs and being, more active than I am now, like running races and racing motorcycles or cars and, just doing stuff that is very calorically dependent and have no trouble staying on top of their nutritional needs, and they are living their best lives. And that's kind of the most extreme example. And I think everyone under there is like, can absolutely make this work. This is the gastric bypass. This is also a relevant operation still. This is the grandfather of bariatric surgery. We don't do as many of these in our practice or in the country just because the laparoscopic sleeve has come along, but it's still a good operation. It's still a relevant operation for patients that have maybe bad heartburn or bad diabetes. It can be a better operation for them than a laparoscopic sleeve. You should talk to your surgeon to see which is going to be the best option for you. This makes a little gastric pouch here. You bring up a piece of small intestine, and then you actually bypass the first part of the stomach, this part of the stomach and the first part of the small intestine. The laparoscopic sleeve, like we mentioned before, it reduces the size of this stomach from this big bag down to this small tube. Durability, these are the best weight loss, 25 to 30% that we see in our practice, and it has the best durability long term. These are all tools. Everything I've talked about so far is a tool. It is not a cure. It's not a magic wand. It's not a silver bullet. There's no such thing that exists in obesity treatment. And I think it's important to have that mindset when you go into this. And whoever's taking care of you should also have that mindset that, hey, these are all just tools. They're not magic wands. And they have strengths and they have weaknesses. The bariatric surgeries are the best tools. They get the most weight loss and they are hands down the most durable. We have the most data on them. And in our hands, honestly, in our practice, we're very safe. We have a surgery center at our place. We also do cases at the hospital, at Evergreen Health. And our complication rate is excellent. Beats the national average by a long ways. We are one of 16 facilities in the country that have a certificate of excellence for bariatric surgery in an outpatient setting. We were actually one of the, obviously, like we talked about before, founders of the outpatient bariatric surgery. And it's been fantastic from a safety standpoint and from an outcome standpoint. Complications are rare, but they can be, complications of surgery: a leak, a bleed, blood clot, infection. They're very rare in our practice. They're less than 1% again, about 0.6%. But when they do happen, we need to make sure you have a skilled team that has a lot of experience in making sure that we get you through safely. Downside of these surgeries is that it's not always covered by insurance. Some people's insurance does have coverage for bariatric surgery, and it is a case-by-case policy decision based on where you're getting your health insurance from. Recovery time is generally about 10 to 14 days, I recommend, for patients. Some patients need longer, and that is totally understandable, and I support that. Many patients are still back to work to their desk jobs at 7 days. And the recovery is generally fairly smooth. They'll be like, yeah, I'm sore when I move around from those incision spots, but hey, I'm chill. I'm getting my fluid in. I'm getting my protein shakes in right now, and they're off to the races over that first month. Their diet progresses. So, how do I take all these? You know what? If you were out there and you're like, I'm struggling. I have tried doing this and I need some help. I don't know which of these I may even want to do, but the first step is just to reach out to our team. So EvivaMD.com, EvivaMD.com /contact us. You can even use this QR code right here, or go to the spot on the website. The way it works, we'll set up, get some information from you to give you all the information about, what does your insurance say? What does it cover? What does it maybe not cover? What's your out of pocket? Do you understand if, from a self-pay standpoint, here's the cost of things. Just make sure you're totally informed when you get set up for your consultation. Get on the schedule. And then usually you meet with us and with our team, with those great group of people before. And we do most of our visits telehealth. If you want to do it in person, you can. But it's very convenient to do telehealth. It is fantastic. We have patients literally from all over the world. We've done surgery on patients from Asia, from Africa, all over the United States, lots of patients in Canada. And we can continue taking care of them. Like, we can continue to do our normal follow-up because we can do all of these things through telehealth. And it has been a fantastic tool for helping patients that are struggling with their weight. Because so much of it is working on all the pieces on this hand, right, to set you up for success, so that we're using that tool to the best of our ability so that it's going to get you the most success we can. At that visit, we're going to review your medical history, your surgery history, talk about, what's been your weight history and what you're looking for. What's sort of your, surgery is really, really scary, but the endoscopic sleeve, that resonates with me. Or the procedures itself, that's just a little bit too spicy for me. Maybe I'm going to go try to do a medication. And we talk about all those options for you, and we just find the best program that's going to be for you, make a plan for you, and then here we go, and off we go. So, if you're ready to start that journey, not that journey, reach out. And yeah, we love this, taking care of patients. It is incredibly satisfying to see you in your journey and making progress, and not just honestly on the numbers on the scale, but there's so many other things that go along with that, the way you feel about yourself and the way that you're actually able to execute so many other things in your life that you want to. When you can make a plan for something, particularly like your diet and your health, and you start being successful in executing that plan, you feel so empowered. So there's so many great benefits of this, and yeah, we're excited for you to get started. So, all right. Thank you all for tuning in. This is a question that I always get, so I'm going to make sure we address it now, which is, what's the diet like before surgery going into it, and what's the diet like after surgery? So we do a liver shrinking diet before surgery. That's about 2 weeks. It is not a liquid diet in our practice. We have found that to be cruel and unusual punishment. If you want to do a liquid diet, you're welcome to. We're not going to stop you. But what our goal is to be somewhere between 12 and 1600 calories. You'll meet with the nutritionist to give you your goals, and about 40 grams of carbs or less every day. And the goal of that is that we want to have you lose some weight on the run up to surgery. And where we want that weight to come from is around from your liver and around the fat that's around your intestines, because that's the place, those spaces sandwich your stomach. And so if we lose some weight out of there, lose some mass, it gives us more space to do the best and safest surgery we possibly can. After surgery, you're on liquid diet for 7 to 10 days, where you're drinking our goal is to get you to 60 fluid ounces, 60 grams of protein. Then we're moving on to a pureed diet for somewhere between 1 to 2 weeks. Then we move on to a mechanical soft diet for about 1 to 2 weeks as well. And then we're moving on to regular texture foods, and we start working with building your menu of what you're going to start looking at long term. And this process of progression usually occurs within a month right after surgery. After surgery, the diet really is lean proteins, some vegetables, and maybe some complex carbs. We want you to measure your food. We have specific portion guidelines from a volumetric standpoint, because if you've had a procedure, you don't want to put too much stress on that stomach to stretch it out over time. And so we also give you goals for calories, for protein, for carbs, for fats. And that way we can help you build this routine and a new menu that's going to really set you up for success for that first year. And if you have a really good routine that you've built, you're going to be set up for success for the next several years. Food that is off limits over time is usually, it takes some time, several months for most patients to tolerate like tough red meat or raw vegetables. And then sticky carbs like sticky rice or sticky bread, we generally try to avoid that because there's not really any very little nutritional benefit to that in general. But it's a great source of energy, but usually that's not the problem when patients are coming to us. So you really want to make sure those are in very small portions. And then the long-term wise is carbonated beverages usually don't sit super well because all those bubbles make big gas bubbles, and there's just not a lot of space in your stomach anymore. But generally, most of the time, people can still eat stuff. They can still have a little bit of treats every once in a while. And we just work with you to make sure that your routine is healthy and that you can still have, some of the things that you enjoy in life. That's not going to change. It's just going to be the portion sizes, the moderation, and the balance in what your routine is normally. And what's interesting about these tools, particularly these last three, the medications, the endoscopic sleeve, the laparoscopic bariatric surgeries, is that you can try to set up that diet ahead of time. We ask this to patients all the time. It's like, okay, you're on this great routine. Could you have done this before surgery or before any of these tools? And it's just like, no. These things really do something on the inside. They really do give you an edge to really help you in the times that we are maintain a healthy lifestyle. So, all right. Well, thank you, everyone. Now we'll go to the live Q&A session, and thank you for tuning in so far. Hello, everyone. Welcome to the live Q&A session. Thank you all for joining us. We have a few questions here, which is fantastic and very exciting. Getting a word here. All right. I got a question from Robert on the insurance coverage. I was grateful your team helped navigate all the requirements and made getting the insurance approval really easy. Yeah, no, that's we've been doing this for a long time, and our goal is to help you get to surgery as smoothly as possible and navigate all these different roadblocks, honestly, that are set up to kind of get patients to weight loss surgery for a lot of insurance providers. It's not getting any easier. I'd say the insurance companies are getting a little bit harder to just to navigate and to get things approved. That's just the environment that we're in. We've been doing it for a long time, and so it's good to have people that are experienced in this realm working on that stuff. So another question that came in on the text line was, what do I do if I'm on Ozempic and I'm not losing weight, or my weight loss has stalled. So, a couple of questions about that. That this is a very common issue that we see. I would say the first thing you want to do is make sure that you are under the care of someone who understands, particularly bariatric surgery, weight loss. You're under nutritional guidelines with that. Going to a normal nutritionist will probably not be as helpful as going to someone with a bariatric experience in nutrition. And the reason for that is that they're very different animals. You should treat a GLP-1 from a weight loss standpoint similar to surgical weight loss in the sense of like your protein requirements and your portion size guidelines. We don't see as much weight loss generally on average with the GLP-1s like Ozempic and semaglutide, but they do have significant downsides of losing lean body mass if you're not watching your diet in a healthy way and losing weight in a healthy fashion. So if you're stuck and you feel like you're plateaued and you're like, man, I still got a long ways. I've lost a little bit of weight on like semaglutide or Ozempic or mounjaro, but I still have quite a ways to go. The best thing you do is make sure, revisit things with your nutritionist, go over your plan, make sure that you have a good plan and that you're following that plan. And also sometimes you're going to see some stalls and sometimes it's just about waiting it out. If you've been on a very prolonged stall and things are, I've gotten my 10, maybe 15% total body weight loss, but I still got a long ways to go. Surgery is actually really good. That's a good time to start considering surgery, because surgery is a really good tool, like we've discussed already today. It really helps with a lot of these things. It doesn't cure everything. It does not a magic wand, but it's a really good tool. It is the strongest tool that we have, and it does complement the the GLP-1s, the Ozempics and the semaglutides and the mounjaros. It complements it well. And so if you're looking like, hey man, I dipped my toe in, I made some progress, but it's time to get more. That is really a good time to do it. And that's when, reaching out is a really important thing, because people say it all the time. Like, this is one of the best things that they've ever done. So it's a great journey, and it's a great thing to be working on. All right. Question about cancers, particularly esophageal cancers after bariatric surgery. So bariatric surgery reduces the inflammatory state of your body in addition to losing weight. We don't exactly know the mechanisms of this. We have some interesting anecdotes. Like, I see this regularly with like rheumatoid arthritis patients, that their inflammatory joint process actually improves quite a bit even before, and their joint pain actually improves a lot before they've even lost a significant amount of weight. And there's inflammatory things that are going on inside of your body that just get reduced with surgery. And obesity itself is an inflammatory state, so that reduces. Plus, obesity and fat tissue particularly is very hormonally active. And that actually drives about over 10 different types of cancers that we know of that are linked to obesity and have been shown to decrease their incidence when you have had bariatric surgery. So the new question that we have been emerging is, with 10-year data now, plus a good amount of 10-year data plus on laparoscopic sleeves, is esophageal cancer as low as with a bypass? Because a bypass definitely decreases esophageal cancer rate. And there is some conflicting data. There are some data sets that show a small increase in esophageal cancer compared to a bypass with a laparoscopic sleeve. And also some data sets have suggested that they may have increased the small percentage of esophageal cancer that happens in general with a laparoscopic sleeve. The interesting thing about that is that some of the first sort of things that it's good to get into this data. It's good to really understand what we need to know. I will say that our early 10 years plus ago laparoscopic sleeves certainly had a lot more heartburn and a lot more issues with them than a current laparoscopic sleeve. So it's not entirely an apples to apples comparison with currently, but we do know that the sleeve has a risk of increasing heartburn, about 15 to 20% of worsening heartburn than what you have now. And heartburn is, a risk factor for esophageal cancer. When you look at the numbers, even when it shows the couple data sets that have shown a small increase in esophageal cancer rates, those are still less than the other predominant cancers that are out there. So And the other benefits of going along with it are still really, really good. But it's something we're going to keep a really close eye on. So great question there. Question from Nermeen. I am going through the process for a potential VSG date before the new year with Eviva. Woo! I am nervous, but ready. Any recommendations for things that can be done to prepare for now? Nermeen, excellent question. So I actually have a video. I'm sure you'll get it with your pre-op video. You can actually probably look for it. It's in our video list on our YouTube channel that I've made for pre-op preparation. And it goes through many things in there about, reminders of making sure that you're working on your portion sizes, tracking your food, doing the high protein, low carb diet. I think that helps get those skills to get the most out of the tool. The other thing is that you want to get yourself strong for surgery, if that makes sense. And I actually tell in the video there, the more strenuous activity that you're doing before surgery, and I'm not even saying this from a weight loss standpoint or a discipline or whatever it is, it's literally just from a physiologic standpoint, the way that your body functions or the way your cells function. If you push your body to its limits, like let's say you go sign up for Orange Theory and you just suffer, right? If you're suffering a couple times, 2 to 3 times a week or more, and you're pushing your body to its limits where you're like, your heart rate's going fast. I'm like, man, this is tough. I really feel like I can't, Dr. VanderWel is the worst. Why are you telling me to do this? This sucks. You are getting coal in your stockings, and from my present this year. If you're in that zone several times a week as you're getting ready for surgery, honestly, surgery will generally be easy compared to that. It tunes up your body, your blood system, your blood chemistry actually, moves, transports good stuff in, bad stuff out better. You increase your natural endorphins, which are natural pain medications. It really does help you get tuned up and ready for surgery. And most people until I take this seriously say afterwards, surgery wasn't as bad as all that stuff you made me do ahead of time. So, thanks and no thanks, I guess. But yeah, that is definitely a helpful one. Get some measuring cups. Getting a belly band sometimes is helpful. That's a little band that you can get on Amazon. It'll stretch around your abdomen and just kind of keeps everything tight in. So when you're moving around after surgery, there's not the shear forces that are going in there that are making those incisions more less comfortable. And I don't tell people to buy a ton of extra like protein shakes or protein bars, stuff like that, because a lot of people's tastes change after surgery, which is very interesting. It's very interesting that doing surgery in your stomach affects your taste buds. Which shows that there's so many things in here that we don't really understand what's going on and how this whole axis works. So a lot of people, they'll go to Costco and buy out a certain type of something, and then after surgery, like, oh, this is dead to me. So don't go too crazy with stuff you think you're going to need after surgery. Get just enough to kind of get you through, and then figure out what you like afterwards and stock up on it once you're kind of in that mess, in that mode. So I think that's most of the stuff, but you're welcome to check out that video. I think I tell people working on the mindset piece too, going through the bariatric mindset workbook is a really good one. I think that's a really, all that stuff is always beneficial. But Nermeen, we're excited for you. So yeah, keep up the good work. Robert, for GERD, I'm controlling it okay with over-the-counter meds for now. Does it eventually go away, or should I expect this is the new normal? It's really hard to say. GERD, particularly after laparoscopic sleeve, is really a weird thing. Some people's GERD, truthfully, most people's heartburn, if they have it before surgery, gets better with a laparoscopic sleeve because there is a relationship between obesity and heartburn. There is a percentage of people where their heartburn gets worse. Sometimes their heartburn gets better and they lose weight, and then if you gain a little bit more weight back, it gets worse again. And sometimes that heartburn is weight related, but it's hard to say. It's really hard to say what is going to happen. So I think the best thing you can do if you have heartburn after any of these surgeries is make sure that you're working with your team and talking to them about it, and that you have a plan. And now our recommendations are to do some sort of at least endoscopy surveillance at some point during this, in the years after surgery, if you're having continued heartburn. So most of the time, if you do have worsening heartburn, it is manageable with over-the-counter meds. We have some exciting endoscopy therapies potentially coming down the line that might help some of this stuff, which I think is really cool. I was working in the lab, with some of the companies a few weeks ago. So it's no, there's some cool stuff. I think we're gonna just keep finding better and better ways to help with this, and help people keep going, keep moving. So good questions. Thank you, everybody. All right. So, yeah. Let's see here. I think that's gonna touch it. That's gonna be it for all of our questions so far, unless anyone has any others. So everyone, thank you for tuning in. And if you have any questions, you're welcome to reach out. You're welcome to put them in the comment section. We'll try to get to them if we see them. YouTube is not my day job, but we do try to make an effort on making sure that we respond to all those comments as well as we can and really get your issues addressed. And we're always happy to help you here at Eviva. So thank you everyone for tuning in. Dr. VanderWel signing off. Have a great day.